Good afternoon, ladies and gentlemen. My name is Brian Chung. I'm the Chief Medical and Scientific Officer of the Hong Kong Genome Institute. Welcome to the Journal Club of Hong Kong Genome Institute. We call it Gene Club. And today we're going to learn something about genomics and bone health. And let me introduce our speaker today, Dr. Janus Wong. Dr. Janus Wong obtained his medical degree at the University of Hong Kong, and he currently serves as the clinical assistant professor in the Department of Orthopedics and Traumatology of the University of Hong Kong. He's a specialist in orthopedics and is a recipient of the Hong Kong Academy of Medicine and Hong Kong Genome Institute Research Excellence Grants for the year 2024 to 25. Dr. Janus Wong's clinical practice focuses on pediatric orthopedics, and he operates at multiple hospitals: the Hong Kong Children's Hospital, the Duchess of Kent Children's Hospital, Queen Mary Hospitals, and Hong Kong Shenzhen Hospital and Glen Eagles Hospital. He has received international recognition for his research from the application of AI in hip fracture prediction, genomic analysis of patients with atypical femur fractures, to prognostications of residual dysplasia among patients with developmental dysplasia of the hip through long-term follow-up. In addition to research and clinical practice, Dr. Wong is the secretary and founding member of the Pediatric Research in Sports Medicine Society Asia Pacific, council member of the Hong Kong College of Orthopedic Surgeons, honorary secretary of the Hong Kong Orthopedic Association Pediatric Orthopedic Chapter, and honorary treasurer of the Osteoporosis Society of Hong Kong. So welcome, Dr. Wong.
Before I begin, I must declare that some of the data is preliminary and unpublished data, and I also have to acknowledge the support from these institutions where I've received funding support, including Hong Kong Genome Institute. So let's begin with hopefully not too common scenario, but it occurred to a family member of mine. So you have a 65-year-old aunt or friend who is quite active, plays pickleball because it's in style now, enjoys the occasional mahjong and going out with friends, and was quite active in life, and unfortunately fell at home, not a high-level fall, not a road traffic accident, but just fell at the bathroom, and noticed very severe right hip pain, and she was unable to walk and stand up. And upon calling the ambulance and arriving at the accident emergency department at the hospital, this was the X-ray taken, which showed that she suffered a right hip fracture. So this is your hip joint. It's the joint that connects your pelvis to your lower limb. And you can see that this part of the femur bone, the thigh bone, is fractured. So you may wonder, oh, it's just a low energy fall, just a slip and just a minor trauma in a bathroom. Why could it have caused such a severe injury that would require surgery and treatment? Well, it's because it's not uncommon among elderly ladies and also gentlemen that the bone mineral density reduces as their age increases. And you can see that the normal bone trabeculae in the normal bone is quite dense. However, in elderly ladies and gentlemen, the trabeculae is reduced. And you can see that the bone mineral density is reduced, and therefore they are at risk of fractures, with hip fractures being sort of the king or the most severe type of osteoporotic fracture. So what is osteoporosis? Well, if we go by the World Health Organization diagnostic criteria, it classifies osteoporosis as more than 2.5 standard deviations below that of normal, healthy young women. And so if we look at the epidemiology in Hong Kong and also in other parts of the world, in Hong Kong more relevant to us because we are having an aging and gentrifying population, we note that over 1 in 3 women over the age of 50 or postmenopausal have osteoporosis. And so by 2047, we estimate that there is more than 1 million elderly ladies and also gentlemen would have osteoporosis. And also it's important to stress that not only ladies would experience osteoporosis, men would also suffer from similar osteoporotic fracture. And so we would diagnose these osteoporosis by dual energy X-ray absorptiometry to know what is the bone mineral density to compare against healthy individuals. However, this is the slightly frightening part because osteoporosis does not have any symptoms. So it does not necessarily cause bone pain and symptoms before you fracture, and also sometimes is referred to as a silent killer. So when you're younger, probably you have less significant, but still fractures with morbidity. You may fracture your wrist, Colles fracture, so you may be out of work, or you may not be able to play mahjong or your activities for a few weeks, but that's sort of still okay. Vertebral fracture, sometimes when you cough or when you're having a abrupt stop, when you're riding the bus or car, you may feel back pain. That could have been a result of vertebral fracture. Still, you may have a thoracolumbar corset. After immobilization and painkillers for a few weeks, you may be able to recover eventually. However, for a hip fracture, then you won't be able to walk, and the treatment is surgical, surgery. We'll come to that in a few minutes, but you can see the type of morbidity for hip fractures is much more significant than the previous osteoporotic fracture. And therefore, as a public health advisory and as an orthopedic surgeon, I hope I can impress upon you the importance of preventing osteoporosis. And it's not that difficult, it's not that hard. For example, simple weight-bearing exercises, some resistance exercises, training up your muscles to reduce the risk of sarcopenia as well. Have a well-balanced diet with calcium, vitamin D, and adequate sunlight exposure. Although I must confess, I also do not have adequate sunlight exposure, but I've just seen your lovely office, and of course the promenade outside would be a sort of an excellent venue for you to have adequate sunlight exposure for vitamin D. And of course the basics, for example, smoking cessation, limiting alcohol intake. So going back to hip fractures, why is it important? Because it is associated with very high morbidity and mortality. So I'd like to draw your attention to here on the on the 5-year mortality for hip fractures. It is as high as 47%. So it is even higher than certain cancers. Say, for example, early stages of breast cancer, thyroid cancer, they do not have a mortality rate as high. So don't be fooled by saying that, oh, a osteoporotic hip fracture is just a fracture. It has significant implications. And just a brief introduction. I understand this is not an orthopedic audience, but we have different types of hip fractures involving different parts of the thigh bone, of the femur. One involves the neck, and the other involves the trochanter. And this distinction is important to us because the surgical treatment would be slightly different. For neck fractures, we may have to replace the hip joint because the blood supply has already been disrupted, but for trochanteric fractures, we may be able to fix it with screws, bones, and nails. And so how do we manage these hip fractures? Well, as an orthopedic surgeon, I'm proud to say that significant advancements and improvements of care have been implemented in both public and private sector over the past few decades. And with a more multidisciplinary approach, with the input of geriatricians, of cardiologists, physicians, anesthesiologists, we were able to reduce the waiting time for surgery and also the risk of complications and the length of hospital stay. And this is important because a quicker or faster or reduced waiting time to surgery has been traditionally one of the key performance indexes or KPIs for a well-run orthopedic service because it has been shown to be associated with reduced patient mortality. Of course, there are also other more recent studies showing, investigating whether we could be more aggressive in terms of waiting time and rushing the patient into operating theater. However, there was no significant difference, but that was just one of the recent developments. So suppose, unfortunately, your friend or your patient has a hip fracture. So what happens actually in the operating theater? So not to scare you or maybe to excite you, so this is my operating theater setup. So you can see all these toys and instruments. So I'm an orthopedic surgeon, so I also get adrenaline rush when I see all these tools and implants and instruments that we have to use to treat patients with hip fractures. And of course, it's not, don't just do whatever you want. There is a lot of evidence and high quality studies performed on how we treat patients with osteoporotic fracture. For example, the type of implant, whether you use a screw or a plate, whether you use the cement in fixing the prosthesis in terms of a femoral neck fracture, and also whether you replace the whole joint, a total hip arthroplasty as compared to part of the joint, hemiarthroplasty. These are all large, multi-center, international randomized controlled trials published in very top journals that have investigated upon. I think I'm not going to go into the details of the surgery, but what I hope to impress upon you is that hip fracture is a major problem. It's something that we face, both in Hong Kong, especially with an aging population. And there has been a lot that has been done to try to improve the care among these patients. And even though although we all try to do our best, but there are complications of patients who suffer from hip fractures and also undergo hip fracture surgery. For example, infection, risk of damaging the nerves, blood vessels, etc. And after fracture, after the surgery or other implant malposition, that's just for the local part, not to mention the systemic part, for example, other medical complications like chest infection, pneumonia, or when, because of prolonged immobility, there is the presence of blood clots with thromboembolism, which could potentially be life-threatening. So the key takeaway, and also afterwards, we also have to rehabilitate the patient. So it's not just that we just do the surgery and let the patient do whatever he or she wants. We also want to encourage them to rehab quicker so that they can return to their activities of daily living and return to their daily life sooner. And so for modern hip fracture surgeries, we would advise patients to do immediate weight-bearing walking. So gone are the days when you just ask the patient to lie in bed for 6 weeks just to recuperate, because that is not without risks, because you may have pressure sores, you may have chest infection, you may have thromboembolism, like the blood clots, as we mentioned. So with the help of our physiotherapist colleagues, we would actually encourage them to walk, to stand, to try to mobilize the sooner the better. So hopefully they can regain their muscle strength and regain their proprioceptive sense so that they can integrate back to society as soon as possible. And this has already been shown with multidisciplinary rehabilitation to improve patient outcomes. And this is the patient journey for a patient who unfortunately had a trochanteric or hip fracture here. So we fixed it with nail and implant with some cement augmentation. And after 6 months, eventually the patient made a full uneventful recovery. And of course, you may say, oh, seems okay, the X-ray and the alignment is reasonably well. But of course, always, prevention is better than cure. And I believe most, if not all of us, would not want to go through the ordeal of having to go into hospital, undergoing surgery, having to bear the risk and complications of surgery. So the important thing, or more relevant thing, is how do we identify patients who are at risk? Which of us are more likely to fracture? For example, I recently also had a fracture, although I'm not as old yet. But of course, and then actually I discovered that I had a vitamin D deficiency, and therefore that's why I was encouraging you to have adequate sunlight exposure. But going back to the topic, so how are we going to identify patients at risk? Of course, there is a general public health advisory asking everybody to try to maximize their bone health. But is there any more targeted intervention, or we can identify patients that are at high risk for fracture? And there is, I think some of us may have heard of it, the Fracture Risk Assessment Tool, the FRAX score, which is, again, one of the tools developed in the UK, and we also have a local Hong Kong version that helps us predict whether patients are at risk of major osteoporotic fractures. So it's not overly complicated to use. However, it's not easy to use as well. So you have to input all your anthropomorphic data, your body weight, your height, whether you have any history of fractures, whether you are on glucocorticoids, steroids, etc., and whether you have done any investigations for your bone mineral density. So this is the current sort of gold standard in predicting the risk of fracture. But how good is this? However, actually previous studies have already shown that this is not particularly sensitive in predicting patients with fracture, simply because the fracture incidence is not as high. And when you have to develop a test and where there's significant data imbalance, it's quite difficult to have a good fracture prediction model statistically. So in the Osteoporosis Society of Hong Kong latest guideline published 2 years ago, which I'm also very humbled to be part of, we try to stratify patients with low, high, and very high risk, and the treatment would be tailored according to the risk. So it allows a more personalized medicine approach, but is still falling short of sort of precision medicine, because as you can see, these risk factors are indeed simply are still a little bit crude and takes into account history of the patient, but of course not all the variables are taken into consideration. But I think this guideline already highlights the importance for us to stratify patients who are at high risk, who are at low risk, because the treatment and the management would be different. But again, as I mentioned, fracture prediction is difficult. So that was why I set out a few years back to see if there is any other way, in addition to traditional sort of conventional statistical models, to help us identify patients who are at risk of having fractures. So this is no longer new now, so everybody knows AI, machine learning nowadays. And in Hong Kong, I think we're very blessed and very grateful that we have very good public health infrastructure, at least for data in public hospitals. So I had the pleasure of collaborating with the HA Data Collaboration Lab previously, of course, with ethics approval and also with all the paperwork. And with that, we had access and collaborated with multiple centers and had access to data of patients who had fractures. So we can try to identify which patients are at risk. And also, because these diagnosis codes are input by healthcare professions, so the data is more accurate, I think, in my view, as compared to, say, insurance claims database or other types of data sources internationally where the kind of data input may be slightly different. So that project some time ago, I looked at patient parameters, including their age, gender, other comorbidities as identified or as coded per the International Classification of Diseases. And we also looked at other parameters, for example, the cause, mobility, the socioeconomic aspects, and as well as the investigation results. And this is just standard machine learning stuff. We divided the sample into a training set and test set for model development and validation. And we compared using a conventional statistical model using multivariable logistic regression and one with sort of AI, so artificial neural network, which is nothing new now, in terms of supervised machine learning. So most of this is structural data, and we did not include image data. So fortunately, we did not need a significant, huge amount of computing power and equipment. Sorry, this keeps jumping. So just did data cleaning. I'm sure for most data scientists here, you're more familiar with this than me. And then we used neural network to try identify or try to classify whether patients were at risk of subsequent fractures with the ground truth. So these patients already had a follow-up of at least 5 years. So I'm not going to bore you the details of how the neural network works through a nonlinear transformation and also through a backpropagation to see whether the prediction was correct or not, and with optimization algorithm. This is not the real weights. This is just an illustration. And so after we've constructed the model, we tested it with our test set to see whether the model was accurate or not. And these were the preliminary results on secondary fracture prediction, so patients who had suffered initial fracture and whether they had a subsequent fracture. And the accuracy was quite reasonable in terms of sensitivity, specificity, so your usual metrics for your prediction models. And the area under curve was quite reasonable. But of course, this is only secondary fracture prediction. We're also some ongoing projects, we're also looking at a primary fracture prediction, which would arguably be more challenging because of the more significant data imbalance. So how do I, my feeling for this field, I think there is potential in developing good models, and it does have real-life implications. However, for the pilot study that I've just presented, we're still in a more preliminary level in using existingly available data points based on clinical history or patient encounters. So in future, I envisage that with the availability or more access to genomic data, to family history, and also to more data points, we may be more accurate, we may be more able to accurately predict which patients are at risk of fractures. As we know, certain genotypes, for example, mutations with WNT1, Wnt1 mutations are more prone to early onset osteoporosis. And also with other AI technologies like large language models on natural language processing or incorporating image analysis would help us increase the accuracy and also facilitate implementation, of course, with collaboration with important stakeholders like our public health system. So that's the earlier part of my presentations. Now let me go to another part of my niche, but a topic that has fascinated me since my days as a young medical student on atypical femoral fracture and how genomic medicine could help play a role in this type of disease. So let's look at this 50-year-old lady who, now, because she's a friend of our previous 65-year-old lady, so she knows about osteoporosis. She has went to screening, had DEXA scan, and identified that she is at risk, so she's taking weekly medication. So she's a good patient, she's a compliant patient, and she takes all these medication regularly. She does not skip any doctor's appointment, and is very compliant with treatment. So one fine day when she was dancing with her husband and her colleagues, she twisted her leg and felt left thigh pain. So this time was not even a fall. It's just twisting motion of her thigh. Although she has been experiencing some vague discomfort for the past few months, maybe. And after that twisting injury, she fell to the ground and was unable to stand and unable to walk. And this was the X-ray taken at the hospital. So again, you can see that there is a fracture over the femur, over the thigh bone. So simple, yes. So same as previous case, just undergo surgery, everything will be all right, right? Well, not quite, because this was a similar X-ray as to the previous patient. Now, this is our typical femur fracture. So they usually occur at the neck. This is the neck part of the femur, of the thigh bone. And you can see that the cortex of this bone is very thin, so the bone mineral density is low. For this patient, however, you can see the bone cortex is actually quite thick. So the bone mineral density is not bad. And this patient is a good patient, she's compliant. So why would she still suffer from this fracture? And we call this an atypical femoral fracture because it is not your typical osteoporotic hip fracture. The location is more distal or more further away from your pelvis. And also the shape of the fracture is slightly different. There is a formal classification for these atypical femoral fractures. So it's not just that it's not just me, I say this is atypical, no. There's a formal scientific classification from the American Society of Bone and Mineral Research, and this is getting more and more important because it is more commonly seen in our Asian population. So as compared to typical hip fractures, the requirement for your surgical technique is more important because you have to put the fractures back into the correct place for it to heal. And also there are also other techniques that we've published to promote bone healing because these fractures tend to take a longer time to heal, in the study that we published previously. So why do they matter? Or why is this sort of a separate entity as compared to the osteoporotic hip fractures that we discussed in the past 10 minutes or so? Is because that they have a high surgical complication risk. So this lady, unfortunately, even after a reasonably well-performed surgery, had a complication. So even the nail broke. So even the surgical implant broke. And the reason is because metal fatigue. Because normally our implants is a race between the implant and the bone to heal itself. And normally bone would usually heal, say, within 3 months, 6 months. But this fracture fails to heal, and therefore it has exceeded the fatigue limit of the implant. And so unfortunately, this patient has to undergo another revision surgery with a large surgical wound dissection, packed in bone graft, and all these other armamentarium that we have. And therefore, and only after that was she able to have a full recovery. And so the cost for each of these atypical femoral fractures is significantly higher, and also the because of these fractures, some patients are getting quite afraid or apprehensive and following doctor's prescription and taking medication. And why is that the case? Or why does that matter? Because you can see that the risk of these atypical femoral fractures, or AFF, is significantly higher among our Asian population. So this is a study published in New England Journal of Medicine up 5 years ago, looking at different patients with different ethnicities in the western coast of the United States, find that the risk of AFF among Asian patients is the highest. And as an orthopedic surgeon, I also see a lot of these atypical femoral fracture patients, one per every month, or even more frequently. And so that is one of the things that has troubled me or puzzled me since I was a young trainee. And we therefore, the next logical question would be to ask what are the risk factors of these atypical femoral fractures. And so in addition to ethnicity, we know that patients with lower BMI, patients with rheumatoid arthritis, patients with certain drugs like steroids and proton pump, like stomach medication and also some steroids, the longer they're exposed to these bisphosphate, because the theoreticized, one of the hypotheses is that this bisphosphate, this medication that helps with treating osteoporosis, actually decreases your osteoclast, the activity of certain types of cells that removes or reduces your bone mineral density. But bone is a living tissue. There is continued bone remodeling, laying down of new bone and taking away old bone that takes place. And just by inhibiting osteoclasts, so a certain type of bone cells that remove old bone away, apparently, although it looks as if your bone mineral density is increased, however, your bone becomes very brittle. So the analogy is like a piece of chalk. It's very hard, but it's very brittle, so it's very easy for you to break it. And also femur morphology. So again, from our previous research experience, Asians have more bowed femur, and that may be one of the mechanical factors. And of course, then, one of our hypotheses is that whether genetics or genomics is also associated with these type of atypical fractures, well, simply because some of these patients are bisphosphonate naive, so they haven't even taken these bone drugs, but they still experience these type of fractures. Other may be because of differences in drug metabolism and bone metabolism. For example, some patients may have metabolized the drugs quicker, so they are less prone to such fractures, but some patients may have different in pharmacokinetics or dynamics, where the half-life of this drug stays in the patient's body for a very, very long period of time. And so even an exposure of, say, 1 or 2 years, then patients may have suffered this kind of complications. And therefore, one of the ongoing researches that our team is doing in collaboration with Hong Kong Genome Institute, and I'm very grateful for the support, is to identify any genetic variations in these patients who suffer from atypical femoral fractures. So this is a multi-center study. We've involved 6 hospitals from different clusters, both universities, over the past, I think this project started for 3 to 4 years, and we have a little over 200 patients now. We identify patients who fulfilled this ASBMR atypical femoral fracture criteria, and we collected blood from them, and we used the osteoporosis studies cohort patients as control, because if we're just using population control, we may be screening out genes for osteoporosis rather than genes for atypical femoral fractures. And we invited them to come back for blood taking, and our initial pilot project was just performing genotyping using Lumina, just a global screening array with limited data points. But now an ongoing project, we're also trying to perform more high-resolution analysis with whole exome, whole genome sequencing with support from HKGI. And our preliminary results do indicate that there is a signal somewhere, and hopefully with further results, we're able to update you on any other final findings, given the increased sample size and also the ability that we're able to perform the analysis now. So, of course, in future, we also hope to see, in addition to whether, to answer the question of which patients are at risk, we also understand which patients are at risk of malunion, so the complication that I just showed you a few slides before of delayed fracture healing. And hopefully that will also guide our management. For example, we can surgically choose to use more stable implants or implants that are less rigid but more biological friendly to promote bone healing. So if we're able to identify, or I guess the importance of the work that we, or essentially what you are doing in Hong Kong Genome Institute with regards to this project, is hopefully we can really have a pathway forward in implementing precision medicine, not only to help us better understand the pathomechanism of this atypical femoral fracture, but also help us potentially to identify any potential biomarkers at risk, or to have a better prognostication tool to have a personalized approach in stratifying patients who are at high risk or low risk of these fractures, and finally have a more personal approach in tailored surveillance. For example, for high-risk patients, we may have to ask them to come back for follow-up sooner, but for low-risk patients, we may spare them the repeated X-ray exposure and ask them to come back at less frequent follow-up. So, in summary, over the past half hour or so, I think, I hope I have shared with you the importance of how osteoporosis is a public health issue, especially in Hong Kong. And given that prevention is better than cure, current advances in genomic medicine and artificial intelligence, AI, etc., hopefully we are trying to investigate how it can help with reducing mortality, reducing the incidence of fractures, and reducing the risk of subsequent complications. And with the help of genomic medicine and AI, we hope that we are able to improve the diagnosis, prognostication of these group of patients, and hopefully implement precision and personalized medicine, management, and improving their outcomes and their lives. And so with that, I'd like to thank you for your kind attention and open up to any questions you may have. Thank you very much.
This is a very great sessions. We learned a lot about bone health and the applications of genomic medicine, as well as the applications of AI in doing various important jobs like diagnosis, prognostication, and treatment-related implications are important in orthopedic practice. So this is the Q&A sessions, and I always have the privilege to ask maybe the first question. I'm very interested in AI. I think what you're doing is great. Using structured data provided by the electronic patient record, we can already see some hints that the AI model performance is better than human. And we actually see this in multiple different areas of medicine, that a machine is better than human performance. Can you tell us why this is the case? From your observation, why would machine prediction sometimes be better than human?
That's a very good question, and expect nothing less from Professor Bryan. So I think if we're using electronic records, and given that the sort of data comprehensiveness we have in Hong Kong, because in Hong Kong we have a unified electronic patient record system that captures data across all public hospitals in Hong Kong, I think the type of data it is available is quite comprehensive. For example, not only say your blood test result, but say the number of inpatient hospitalizations that you may have. And that in itself may also reflect upon the general frailty or the general overall patient health and condition. And also with the number of variables that we can investigate, of course, there's always the risk of overfitting, and also there is also the issue of how data is entry, because different hospitals may have different practices. But still, I think that kind of information is beyond the processing of at least my simple brain. Maybe not you, but a lot of our frontline clinicians, they simply, we may not have enough time to process this amount of data to come up with a judgment. And so I think this is one of the areas where AI, machine learning, or data could help us. And also, in comparison to traditional conventional statistical models, I think, say for example, neural networks and other models, they may be able to find out or potentially identify any potential associations that we may have overlooked or we did not notice. And of course, if there are any data scientists and informaticians, please correct me if I'm wrong. But of course, neural networks is already old. There are also many other newer models. Of course, but I do acknowledge that there is sometimes the issue with the black box model, that we're not sure whether there would risk introducing some unknown bias. And explainable AI, for example, through Shapley's additive explanations or tree explainer or other models, we're trying to work towards that, but I'm not sure whether we're quite there yet. But anyway, I think AI and machine learning could have a role and could be better than just, say, for example, just me looking at a patient, looking at 2 pages of medical records and telling what the fracture risk of this patient might be.
If you allow me, I have 2 follow-up questions. Of course, you are like a brilliant clinicians. And I remember when we were in medical schools, what we learn in data analysis may be something that is completely dependent on statistic modeling and statistic methods. AI is really something new. Can you share with us your experience when you try to self-learn how to do analysis using machine learning and AI? What are the hurdles? And what would be your advice for people who are still in training, both clinicians and scientists?
Sure. Thank you very much for your question, Professor Bryan. So I'm not sure I'm an expert myself, but I think when I was a student, at least, AI was not part of the curriculum. And when I was in secondary school, the computer language that I learned was Pascal. It was it was not until after I've graduated, then Python became a big thing, and then we start to learn. So I think advice would be, but it's just my feeling, is to have a good friend or somebody who is also interested in the same field. For example, I'm very blessed to have a friend who's also very interested in statistics and in AI, that sort of stuff. He is also a medical doctor, actually my medical school classmate, and we learned together. So there are a lot of resources online, GitHub, even YouTube, and a lot of resources that could help with learning the basics. And I think I'm an experiential learner. I don't know if that's the correct word. So I need to learn through a project or through an example. And this was my, I think, third or fourth project. So I had smaller projects before that I tried applying AI. Of course, it's much more simpler and compared with other conventional statistical methods. And also, of course, don't be afraid to fail. Because always, I remember one of the first models after I used AI, and the accuracy was 90%. And I was patting myself on the back. Oh, it's a good job. But then I found, because most of my data is skewed, so it's an imbalanced data set. So I found that my additional model simply just guessed all the patients didn't have any fracture, say, for example. And because only, say, 10 patients out of 100 patients have fracture, so my accuracy is 90%. But of course, you know that model is meaningless because it does not do anything. So I think having a good friend, being open to different modes of learning, like not only a textbook, but to online resources, and not being afraid to fail would be my 10 cents on this topic.
Thank you for the sharing. I experienced what we call a generation gap when you tell me about the computer language that you're using. Because for me, I learned BASIC. I don't know whether you guys even know what is BASIC. And the other thing that I think that echoes a lot is experiential learning through a project that is dear to your heart. And that's why in Hong Kong Genome Institute, we have different kinds of scholarship trying to support researchers to do projects related to genomics and genomic medicine, and see how we can support them not only through the budget, but also through the expertise and the resource that we have in order to help to push some project forward and to advance all the learning experience of clinicians and scientists in Hong Kong. Maybe another follow-up question. In one of your future plans on the AI parts of your project, you did mention a few additional things that you want to do. One is, of course, genomics. Second is imaging. And the third, I see very interestingly, is the electronic patient record for private medical practice. Perhaps you can share with us your thoughts about your future plan. How would these new resources help to improve your model? Is it just in the secondary fractures, or would they be even helpful in the primary fractures that you have already told us in your talk that this is going to be a little bit more difficult than secondary fractures?
Yes, that's a very tricky, difficult question. So because I think in Hong Kong, our healthcare system is also undergoing some evolution and change, we're trying to have heavier primary healthcare presence. And so I think, but you know, as our current level stands, most of the primary healthcare doctors, for example, the doctors that you see when you have upper respiratory tract infection, when you have cough, is I think most of us would go to a private family doctor, and those records are not captured within the public healthcare database. And I think if we are able to link up with the private database, of course, the data has to be structured, it has to be using the same system, and also we have to go through all the ethics and also the regulatory steps to ensure that privacy is, of course, ensured. And if we are able to do that, I think we would be able to obtain more high quality data, because the prediction model that I just showed works reasonable among patients who use the public healthcare system. But for those who use a private healthcare system or only goes to private hospital, then my model is not as useful, because simply it does not have the data points necessary to have a good and reasonable prediction. So I think in future, if that is feasible, of course that's a very big if, then the accuracy and what we can do would be much more.
Thank you so much. I cannot be too selfish. I need to open the question and answer session to the floor. And for those who are joining us from Zoom, please also type your questions in the chat box. So I would like to see if from the floor. Oh, okay. So Dr. Ma, our lead scientist.
Thank you so much for this inspiring talk. I'm also start my computer programming from Pascal, so I know what that is. But now, as you introduced, we are switching largely to AI and large language model. I'm particularly interested in one of your mentioned. Dr. Jung also asked is how to process those clinical notes, free text notes in the electronic health record into data that can be processed by the AI. So we are exploring the large language models. Have you tried what types of model are powerful enough to process these data? Because nowadays we have models some very basic, very easy to run. Those require less resources to very resources intensive. So those large language models. Can you share a little bit more about your experience on this?
Oh, yeah. Thank you, Dr. Ma, for your question. Well, personally, I have limited experience in large language models because for us to use free text entry is quite labor intensive. So for example, for structured data, it's not easy, but relatively easier to have, say, patient's blood result, say, for example, calcium level, for example. So you can input that. But for free text data, then the variability is more, and also at least with the previous projects I had with, of course, IRB and ethics approval, it involves individually exporting the text from that patient's medical records, and sometimes there may be a lot of 50, 60 medical records, and they come from a variety of different sources. So it could be a doctor's notes, it could be a physiotherapist's assessment. And I'm as knowledge, I have limited experience in using a certain model because for me, I'm still trying to ascertain the best way to do data cleaning. Say, for example, for a blood calcium level, then I would know, for example, within this range is physiological. So any values above that, I know it's not incompatible with life, so I already exclude those. But for some free text entries, at least from some pilot projects that I've done, I realized that some of the records, I'm sorry to say, because I'm also one of the frontline clinicians typing records. Some of them are simply not accurate, and some of them are downright contradictory. So I think so I haven't gone to the step of constructing large language models, but I do hope that if we have a better way to ensure the data quality and ensure that what is input in the model is accurate, then subsequent steps, for example, in constructing a large language model would be a much better or less difficult way forward.
I completely echo because I'm one of the contributors for the bad medical writings in the charts. I think within hospital authority, there's a different discipline that starts to use what they call clinical templates for important and common diseases like strokes or ischemic heart disease. That will make those unstructured data a little bit more structured.
Yes.
Those would be very helpful if we need to extract information from the clinical notes. They are not that unstructured in a way because they would limit the amount of information and where you place those important information in a particular part of the clinical record.
Yes.
That would be something that we have to think about. That would not only improve the clarity of our medical notes, but it would also facilitate advanced data extraction combined and integrated with machine learning models. I think those are the direction that we should probably follow on different aspects.
Yes,
I would like to see, there are more questions. So another scientist, Dr. Ying.
Yeah, this is Johnson from a medical scientific team working on biomedics. So I have a question related to the neural network you are working on about the input and output data. So it's also related to previous discussions. For the input, I'm just wondering, were you able to distinguish the clinical medical records by the timestamps? So are you only able to select the ones that before the fracture actually happens, or it's difficult for you to handle that? And the second question is from the output. After the prediction for neural network, normally they will not tell you what are the factors, but were you able to emphasize the results and see if there is anything special or out of expectation, any factor you find it is contributing to the prediction? Thank you.
Thank you, Dr. Johnson, for a question. So for the first question, yes, so that depends on your study design. So for that project, we only included patients with at least 5-year follow-up. So we excluded patients who were just recently seen. So then we have at least 5 years of prospective data to know whether they really had a fracture or not. Because sometimes it's not very reasonable to say just include a patient who just first seen yesterday. And so he or she doesn't have a fracture today, doesn't mean that he or she won't have a fracture, say, tomorrow or 1 month from now. So I think that would be the methodological design way. The second one is we did find some hints on some serological parameters about a hematological complete blood count profile. For that, we just used the SHAP value, and that sort of, there isn't one particular value that stands out from the rest, but yeah, some blood counts were, appears to have some signal. But of course, if we just use that single variable in itself, using univariable analysis, we were not able to have a good prediction on whether the patient has subsequent fracture or not. So I think to answer your question, yes, there may be a few, but I think just using that few variables, it would be insufficient to have the performance of the whole model.
Thank you, Dr. Wong, for your amazing presentation. We are very interested in the AI part, and we're also working on other project about the AI implication to genomics. And I want to ask for your selection in the model algorithm. You select the neural network, and we know that there's also other algorithm and models in other study. And may I ask, do you select this model based on some rationale for your data set, or have you also tested on other algorithm? This is the best algorithm to use. And also I want to ask for the running time for your data set, because there are a lot of different clinical data from your data set. And the running time, is it short, or it will take a long time? Also the data resources requirement, is it also acceptable for your study?
Oh, thank you very much for your question. So yes, indeed, we did have tried different models. So other tree-based models like random forest, XGBoost, and of course there are also neuroconvoluted long-term memory models, etc. But this was one of the models using our preliminary data which has the best performance. So I'm sorry, I'm a little bit biased because I omitted the other parts. For your second question, because most of this data, although there are a lot of parameters, but most of them were textual and structured data. So it didn't take a long time, just a few hours. I think if I include the X-rays, it would be a different story completely.
Thank you very much. So maybe I will follow with another questions on the genomics part of your talk. As you know, this is a Genome Institute. We're very interested in that. And this is something that I agree is important to be studied in Hong Kong, the atypical femur fracture, because it's an Asian condition. You did share a few risk factors for this very strange femur fracture that occurs in patients perhaps with osteoporosis. Is there any mechanisms that you can propose that may explain how these risk factors will lead to the atypical fractures? Because as you have correctly mentioned, we are collaborating to see if we can find the genetic answer for this particular conditions called atypical femur fracture. Of course, genomics can do things in a hypothesis-free manner, but sometimes some guidance will be good. So if you can actually share with us what are the known models and rationale or the mechanisms behind this atypical fracture, that would be useful.
Sure. So I'm an orthopedic surgeon, a simple guy, so I'll talk about some simple stuff. So one of the risk factors is anterolateral bowing of the femur. So your thigh bone is not straight, mostly straight, but not, it's actually a bit bowed. And we recognize that in Asians, there is more anterolateral bowing. So if you look from the side, it's not a straight bone, but it curves anteriorly and then goes posteriorly. And same, when you look from the front, it goes lateral or goes to the outside and goes to the medial side. And the reason why that could be a possible pathomechanism is because load is transmitted either through compressive stress or tensile stress. So compressive stress is just at the medial side, when the bone is opposed to each other. Another side is tensile stress, when the bone is pulled apart like a taut piece of string. And these atypical femoral fractures, all of them occur at the tensile side, so at the lateral cortex of the femur. So when you look back on the criteria, then the fracture always starts on the lateral side. And there are certain genes that affect limb development and limb morphology. SOX9, PTX1, just a few. I'm sure Professor Brian knows more about embryology as a pediatrician than me, but this is just one of the examples of how the difference in gene expression, for example, may have influenced the risk for atypical femoral fractures. Of course, this is just the physical or biomechanical side. There's also the biology side. For example, the activity of osteoclasts in removing a dead bone, or whether the drug bisphosphonates and how the body metabolizes that drug. I think those could also affect the risk for these atypical femoral fractures.
So you see, this is a very important interaction between the clinical team and the people doing the genomics, because if we think about this problem of osteoporosis and atypical femur fracture, we may think of something that is more related to the degenerative side of things. But from what Dr. Janus Wong has just told us, is actually to do with the 3D bone orientation of all the bones in the lower limb. So maybe the development, something occurred early on in life, predisposed you to have a problem later, which could actually present only when you get osteoporotic, and then you may develop fractures that are atypical. And of course, the other way that in the Genome Institute we're exploring is for those conditions that maybe the mechanisms is not that clear. The new methodologies like multiomics, studying the proteomics, the metabolomics, and the transcriptomics may help us to understand the mechanisms behind that. So that may be also something that we can explore and talk together to see if those are newer methods we can employ in this particular project.
Yes.
So as a habit, the last questions we would be asking you would be a more general health advice. You certainly have given a lot of advice on people that reach the age that may be more at risk of developing osteoporosis, what we shall do. Is there anything we shall do as a prevention? So for the younger generation in the audience, what should they be doing? Vitamin D is important. What else?
Physical activity, I think. Although I struggle myself, so I have to be honest. I am not as active as I hope I could be. But because bone mass, building up your bone mass early in life is very important. And the benefits actually still accrue to your later part of life. So having a lot of weight-bearing physical activity, having a balanced diet with calcium, vitamin D, adequate sunlight exposure, I think all these are important to have healthy bones and stay alive, live longer, and live happier or more active.
Yeah, and more physical activities have more benefits than just bone health.
Yeah, exactly.
In many different aspects of health, yes. Thank you very much. I hope that you enjoyed the talk as much as I do. Let's thank Dr. Wong in the usual manner. Thank you very much. So I'm very happy to close this session, but before I go to close this session, I would like to do, again, some advertisement. Now, this time we're talking about bone age. Next time we are talking about child development. So I'm very interested to tell you, and very excited and proud to tell you that next time, the speakers of our Gene Club will be from our own institute. Actually, the two of the speakers have already asked some interesting questions just now. We have Ms. Dream Chan, a senior genome curator, and Dr. Ma Wai, our lead scientist, to tell us more about how we can use genomics to help children with developmental problem next time. So stay tuned. Thank you very much for your kind attention. Bye-bye.